Good evening, dear students. Welcomes to the second ISA online PG class for MD, DA and DNV students. Today, we have got a very eminent teacher of teachers, Professor Dr. Sunanda Gupta, head of the Department of Anesthesiology at Gitanjali Medical College, Udaipur. She has held very important positions across the country, not across the country, across the globe. Madam is founder president of AOA, Association of Obstetric Anesthesiologists. Madam is executive member of Working Committee, Indian College of Anesthesiologists. She is a member of editorial board of JOCP and JACP. She is member of Obstetric Anesthetics Association UK, executive member of Obstetric Anesthesia Society of Asia Oceania. She has got hundreds of publications, and Madam has given us a very nice textbook on obstetric anesthesia, which was released way back in January 2005. And Madam is editor of that particular book. And I'm lucky that I also contributed one chapter on amniotic fluid embolism on that particular book. Madam has got numerous chapters in international books, national textbooks, and more than 150 publications in national and international journals. She has got 6 awards, 8 orations, and hundreds of conference lectures to her career. And she has been a guest lecturer at international conferences in Sri Lanka, Iran, Poland, Karachi, Singapore, Hong Kong, World Congresses, London, Boston, Jakarta, Manila, almost every part of the country and every part of the world. Ma'am, it's really a pleasure and honor to have you as a faculty. And ma'am shall be talking today about a very important clinical topic, pregnancy-induced hypertension. I have muted everybody, and you can type your questions in the chat box, and it will be between you and madam. Over to you, ma'am, for your classroom teaching. Madam Sunanda Gupta, please.
Thank you very much, Dr. Naveen, for that kind introduction. And I thank ISA for including me as faculty in these master classes for the postgraduates. So now we are going to talk about a very important topic, and that is pre-eclampsia. Now this topic which has been given to you is just to highlight that this pregnancy-induced hypertension is an obsolete misnomer, and why it is so, I will talk to you as we go along this lecture. And PIH is now called pre-eclampsia, and as I said, we will be talking about it as we go along. So before I start my lecture, I bring to you greetings from my medical college, Gitanjali Medical College and Hospital. It is a 1,500 bedded hospital, and it extends right up to the foothills of Aravallis, and it is extending at a great pace. We have nearly all the super specialties here. And an overview of what to expect in the next 1 hour or so. We'll classify the hypertensive disorders of pregnancy. We'll talk about the pathophysiological changes, what are the clinical features, and what are the effects that occur in the various organ systems. We'll talk about the anesthetic management, and we'll talk about what are the complications that occur, and then some key questions from you all I'll be answering. So the first question is, how do you define pre-eclampsia? Now, pre-eclampsia is defined as the new onset of hypertension and proteinuria after 20 weeks of gestation. Now, if there is no proteinuria, in the absence of proteinuria, there should be signs or symptoms of any of these end organ involvement. Persistent epigastric or right upper quadrant pain, persistent cerebral symptoms, fetal growth restriction, or thrombocytopenia or elevated serum liver enzymes.
And you plan to share your slides?
It is not shared.
No, no, not, you're not yet shared.
Oh.
So I thought.
Can the screen be seen?
Yes, now it's absolutely clear. And you can just go one slide back, ma'am, if you don't mind. Yeah, that's fine. Right.
So an overview of what to expect in the next 1 hour or so. We'll talk about classification of the hypertensive disorders of pregnancy. What are the pathophysiological changes, the clinical features, and what is the anesthetic management? What are the complications that occur? And then we'll talk about some of the key questions. So how do you define So how do you define pre-eclampsia? It is defined as the new onset of hypertension and proteinuria after 20 weeks of gestation. And in the absence of proteinuria, if there is no proteinuria, then there are signs and symptoms of end organ involvement. So any of these signs or symptoms could be present. The patient could complain of persistent epigastric or right upper quadrant pain, persistent cerebral symptoms like severe headache, fetal growth restriction, thrombocytopenia, or elevated liver enzymes. Now then, how do you classify the hypertensive disorders of pregnancy? It is gestational hypertension, means the hypertension starts up to 20 weeks of pregnancy. And that is why it has been separated from pregnancy-induced hypertension, because both denote the same thing. And there are 4 classifications of hypertensive disorders of pregnancy. Pre-eclampsia has been divided into pre-eclampsia without severe features, which we used to call as mild pre-eclampsia, and severe preeclampsia. So never say that preeclampsia is mild, moderate, and severe. Then we come to chronic hypertension. The patient may be having it even before she became pregnant. And the 4th classification is she already had chronic hypertension, but preeclampsia gets superimposed when she gets pregnant. Now we come to the pathophysiology, which is very important. And this is how we come to know why these changes occur in the organ. It is a 2-stage disorder. First is the asymptomatic stage, wherein you have an abnormal placentation. And the second is a symptomatic stage, which has widespread endothelial dysfunction. Till there is abnormal placentation, no symptoms appear. It is only in the second stage that your symptoms will appear. If you look closely towards this diagram, this is the normal fetoplacental unit in normal pregnancy. And what you should appreciate is that both the decidua and the myometrium get invasive cytotrophoblasts, which are of fetal origin, and they invade the maternal spiral arteries and convert it from a small caliber resistant vessel to a high caliber capacitant vessels. Now, what is important is that these are non-responsive to the vasomotor stimuli, and so the placenta gets good placental perfusion through it. While in pre-eclampsia, you will appreciate that there is no invasion of the cytotrophoblast in the myometrium, and even in the decidua, there is only partial infiltration of the cytotrophoblast. The spiral arteries stay on as small caliber resistance vessels, and they're very hypersensitive to vasomotor stimuli. So there is no free flow of blood through it, and thus placental ischemia occurs. So this was about abnormal placentation. And the second important adaptation that occurs in pre-eclamptics is endothelial dysfunction. Now you'll appreciate that in the healthy endothelial cells, there is release of anticoagulant and vasodilator factors. So soluble FLT1 and the endothelial growth factors, as well as the growth factor from the placenta, they all are released in modest concentrations in the normal pregnancy. But what happens in pre-eclampsia, that soluble FLT1 is, the levels are much higher, and they inhibit the circulating growth factors from interaction with the endothelial cell surface receptors. So what happens is there is endothelial dysfunction. You can appreciate that endothelial dysfunction here. I'll show it later on in another diagram. It causes decrease in prostacyclin, it increases the nitric oxide production, and there is release of procoagulant proteins, which are important for all the endothelial cell dysfunction that occurs in different organ systems of the body. The third important feature we need to know about is the clinical features. So pre-eclampsia without severe features, which you used to call as mild pre-eclampsia, the blood pressure is more than or equal to 140 by 90 millimeter of mercury, more than 20 weeks gestation, and taken 2 times 4 hours apart. There is proteinuria, 1+ on urine dipstick, and significant proteinuria is denoted by more than or equal to 300 milligram in 24 hours. A protein creatinine ratio or an albumin creatinine ratio will be more than 0.3 or 0.8. Now, in severe preeclampsia, one of these symptoms or clinical features or signs will be present. Blood pressure is definitely going to be above 160 by 110. Thrombocytopenia can be less than 1 lakh per cubic millimeter. Serum creatinine concentration greater than 1.1 milligram per DL, or maybe 2 times the baseline. Pulmonary edema may be present. There may be new onset cerebral or visual disturbances and impaired liver function. It is also classified as type 1 or type 2 preeclampsia. Type 1 is early onset, and always remember early onset preeclampsia before 34 weeks of pregnancy is always more dangerous and leads to more complications. The resolution of symptoms in late or type 2 preeclampsia occurs in 48 hours, while in some cases you'll find that preeclampsia does not appear during the period of gestation and delivery or labor, but it appears postpartum within 7 days of delivery, and that also is known as preeclampsia. So what are the risk factors which will lead a pregnant woman towards preeclampsia? Age, more than 35 years, Black race or Hispanic, genetic factors. Even paternal genes are responsible for consecutive pregnancies becoming preeclamptic. That is quite a surprising finding recently. Comorbid conditions like obesity, diabetes mellitus, chronic hypertension, chronic renal diseases, or the phospholipid syndromes and SLE, all these will precipitate preeclampsia in the pregnant woman. Similarly, multiple gestation and hydatidiform mole and chronic smoking in the pregnant woman can also lead to preeclampsia. This is a flow chart showing the effect on various organs, quite a busy chart, but I'll try to simplify it. There are multiple factors which lead to endothelial activation. It will lead to vasospasm, capillary leak, and activation of coagulation. Remember, these two go hand in hand. Activation of coagulation along with thrombocytopenia can lead to HELLP syndrome, while vasospasm in the different organ systems are going to produce different effects, like if it can cause hypertension, seizures, and hypertension can cause seizures and eclampsia. Uteroplacental insufficiency can cause oligohydramnios, IUGR, or abruption. CNS dysfunction and visual disturbances can occur if the brain perfusion is reduced. Similarly, if liver perfusion is deranged, then it can lead to hepatocellular damage with thrombocytopenia. Decrease in kidney perfusion can lead to acute renal failure. And capillary leak, the major complication that occurs is pulmonary edema and hemoconcentration. So we take each system separately and we look at what changes occur. In the central nervous system, the patient may complain of severe headache, hyperexcitability, hyperreflexia, and coma. The visual changes that occur in pre-eclampsia because of these changes are scotoma. Now, what is scotoma? Scotoma is appearance of blind spots in the field of vision. Amaurosis is appearance of partial or complete blindness. Blurred vision and acute cortical blindness that occurs in severe pre-eclampsia. So why do these changes occur? Basically, it is because there is loss of cerebral vascular autoregulation and there is vascular barotrauma. The hyperperfusion of the brain due to endothelial dysfunction leads to vasogenic edema. Now, what happens because of this endothelial dysfunction? In the placenta, there is release of NK cells, genetic factors, or oxidative stress. All these lead to release of leptin molecules, and these are responsible for platelet aggregation, and these also accelerate the coagulation cascade. Similarly, SFLT1 and soluble endoglin, their levels are increased, and other mediators, they all cause endothelial dysfunction. They also stimulate the coagulation cascade, and they also cause seizures. So seizures along with cerebral thrombosis go hand in hand with endothelial dysfunction. So the predictors of disease severity according to the neurological markers include two sophisticated tests which have recently been introduced. The optic nerve sheath diameter, which if it is more than 5.8 millimeter, can forewarn us that there is an increase in the intracranial pressures. Regional cerebral hemoglobin oxygen saturation is decreased in pre-eclampsia, and it has been found that when you start magnesium sulfate, these levels come back to normal. Now, the airway in pre-eclampsia, the internal diameter of trachea is reduced because of mucosal engorgement. Pharyngolaryngeal edema decreases the upper airway, the space in the upper airway. The signs of airway obstruction, dysphonia, hoarseness, snoring, stridor, hypoxemia can occur. So always remember, you need to keep a small endotracheal tube when you are intubating such patients under general anesthesia. Another important finding has been that the myelopathy grade 1 can increase during the course of labor. As the patient progresses in labor, she may, either because of fluid infusion or because of the strain of labor, there is a change in the airway grading, and it may change from grade 1 to grade 3. So always do a airway examination just before you are putting the patient to sleep under general anesthesia. These patients are more susceptible to obstructive sleep apnea, and recurrent nocturnal desaturation can affect the placental circulation. The cardiovascular changes again are very complex in nature because they undergo changes according to the progression of the disease and also according to the treatment that has been instituted. There is an increase in vascular tone, increased sensitivity to vasoconstrictors or catecholamines, and the plasma volume in severe pre-eclampsia is reduced by 40%. This leads to hypotension, vasospasm, end organ ischemia. And if you look at this diagram, these patients have a low plasma volume, a low colloid osmotic pressure, a low or normal CVP, and an increased PCWP. The CVP and the pulmonary capillary wedge pressure, their values do not match, and so they are really of no use in a pre-eclamptic parturient. The systemic vascular resistance may be mildly or severely raised. Myocardial contraction may be increased, and there could be low, normal, or increase in cardiac output. So basically, it is a low volume, high pressure, high resistance system that we are looking at. There's a hyperdynamic left ventricle. The patient may go into diastolic or systolic dysfunction. The hematological changes which are of concern for us, there is thrombocytopenia, mostly less than 1 lakh, we call it thrombocytopenia, and a platelet degranulation shows us the quality of the platelets also reduced, and enhanced platelet aggregation causes a decrease in the count. And these can be seen more in DIC, severe liver disease, placental abruption, and PPH. Now, how will you find that the coagulation system is activated? Because that changes your management strategy. The consumption of procoagulation factors like fibrinogen and platelet count will be decreased. There will be an increase in the fibrin degradation products. On histopathology, microthrombi in organs have been found, and there could be hemorrhage. So thrombocytopenia and the dreaded subarachnoid epidural hematoma, there's a delicate balance. There's a high compliance in the epidural space, and on the other hand, you have a decrease in platelet count. And so there are two different situations we see in preeclampsia without severe symptoms and preeclampsia with severe symptoms. There is hypercoagulability in the earlier forms of preeclampsia and hypocoagulability in the severe preeclampsia. The hepatic changes, why does the patient complain of epigastric or right upper quadrant pain, is an ominous sign, and it could be because of distension of the capsular, liver capsule because of subcapsular or parenchymal bleeding. There's also periportal hemorrhage and fibrin deposits which are present in the sinusoids. All are ominous signs, and hepatic changes always forewarn of a severe preeclampsia. The renal changes that occur, there is persistent proteinuria. The glomerular filtration rate normally is increased in normal pregnancy, and the markers of renal function are decreased like blood urea nitrogen, serum creatinine, and serum uric acid. But here the glomerular filtration rate is decreased, and the best part is that these markers of renal function may show to be normal in spite of a decreasing GFR. So you need to be cautious in preeclamptic parturients when you find the markers being normal. There'll be hyperuricemia, oliguria, and progression to ARF quickly can occur with DIC, placental abruption, and hypovolemia. So why does proteinuria occur? Now this diagram shows you the glomerular endotheliosis. There is vascular damage with systemic inflammation. And if you look closely, the vascular endothelial growth factors, the heparan sulfate and the chondroitin sulfate, these are the bars, they all form a barrier which prevents the anionic albumin from going down through the urine. But what happens in the preeclamptic parturients, as I told you, the SFLT1 increases significantly as compared to VEGF, and this prevents the VEGF from binding to the surface receptors here. Similarly, the heparinase, it binds with the heparan sulfate and prevents them to combine with the surface receptors, and thus you find that there is albuminuria that occurs. Now, uteroplacental perfusion, mostly advocated by our obstetricians, you'll find this is the normal picture and this is the pre-eclamptic picture. There's an increase in downstream resistance of the fetal umbilical artery waveform, a decrease in the diastolic velocity, and an increase in the systolic flow and the diastolic flow velocity. The ratio is increased. And severe pre-eclampsia, it leads to fetal growth restriction. Now we come to the obstetric management. Now the timing and route of delivery. We'll look at how to control the hypertension, how prophylactically prevent seizures, and what to do about maternal and fetal surveillance. So decision regarding delivery, improved maternal outcomes always occur if induction of labor is more than 37 weeks gestation, so that you have a viable fetus on your hands. With severe pre-eclampsia, delivery can be instituted at more than 34 weeks gestation. Now, if it's not an emergency, you can delay it for 24 to 48 hours to start your corticosteroids so that fetal lung maturity occurs. If complications are present, then you need to expedite the delivery, whatever the stage of pregnancy. If it is refractory, severe hypertension, persistent cerebral symptoms, then any time of gestation, you should be doing your cesareans, or you should induce the woman. So remember, delivery is only cure for pre-eclampsia because we need to remove the placenta as soon as possible. How will you control the hypertension? There are 3 frontline drugs which have been advocated, and these are labetalol, hydralazine, and immediate release nifedipine oral capsules, not the sublingual one. Hydralazine is not yet available freely in our country. Intravenous labetalol, start with 20 milligram, go up to 80 milligram, and the maximum dose you can give is 300 milligram in 24 hours. Nifedipine, you start with 10 milligram doses, then 20, then 20, and if there is no response, you can go back to your labetalol. In non-severe hypertension, that is without severe symptoms, you have your oral drugs, methyldopa, nifedipine, labetalol, and beta blockers. Remember, you need to be cautious with labetalol, not to give it in asthmatic patients. The control of convulsions, parenteral magnesium sulfate intravenous. The initial loading dose is 4 grams and maintenance regime is 10 grams. You give an infusion 1 gram per hour through the infusion pump. That is the safest. But always remember, the volume you are infusing, you should also include it in the intake output chart. Now, seizure, if it occurs while the patient is on magnesium, then you need to give an extra dose, 2 gram, 10 ml IV over 5 minutes. If still the seizures persist, then you can switch over to phenytoin or diazepam along with your Maxil or thiopentone if it's available with you. And if again there are persistent seizures, nothing helps you, then you need to intubate these patients and send them to the intensive care unit with IPPV. So how does magnesium help to control the seizures as it is a vasodilator? A very interesting question which most of the examiners ask you. Now, what happens is there is abrupt sustained increase in blood pressure which forces the vasodilatation of cerebral vessels. There is hyperperfusion and leads to cerebral edema. Now, what happens with magnesium is that there is preferential vasodilatation in the mesenteric vessels, which causes an increase in the peripheral vascular resistance. And it also ameliorates the neuroinflammation and brain edema. It protects the blood-brain barrier, acts centrally at the NMDA receptors to increase the seizure threshold. And that is how, though it's a vasodilator, it helps in controlling the seizures. Another important question, what is the normal serum magnesium levels? You should know 1.7 to 2.4 milligram per DL. The therapeutic levels would be 5 to 9 milligram per DL. You should note the loss of patellar reflex at what levels of serum magnesium it appears, 12 milligram per DL, and respiratory arrest at 15 to 20 milligram per DL, and asystole more than 25 milligram per DL. Now, there are some precautions you need to take while you're starting your magnesium sulfate. Your potassium levels should be ideal, normal, before you give your intravenous MAC-Sulf. You should know about any neuromuscular disease or myasthenia gravis, because that is going to increase the duration of your neuromuscular block. In patients with renal impairment, you need to be cautious because it is totally excreted by the renal system. And with digitalized patients, because of the potassium aberrations, you need to be cautious. When should you stop your MAC-Sulf? Whenever you find that you cannot elicit the deep tendon reflexes, you should put a stop. If the urine output is less than 100 ml in 4 hours, shows renal impairment, stop it. If the respiratory rate is less than 16 per minute, remember it could be respiratory depression because of MAC-Sulf. And 24 hours post-delivery, you need to stop this drug. So how would you stop, how would you manage these patients who are headed towards magnesium toxicity? Stop the MAC-Sulf, try to estimate the serum magnesium levels if possible, and restart the dose according to your magnesium levels. And if there is respiratory compromise, 10 ml of 10% calcium gluconate intravenously should be given. And if required, airway protection with intubation should be standard treatment. Now, a pre-anesthetic evaluation before you subject the patient to operative delivery or labor analgesia. Your focus should be on airway examination, the maternal hemodynamics and the coagulation status, the fluid balance, and magnesium monitoring. Confirm your diagnosis, control the blood pressure, prevent convulsions, and timely take a decision in the multidisciplinary team regarding the mode of delivery of these patients. So always look out for end organ involvement. If there is a severe headache, altered mentation, visual disturbances, CNS hyperexcitability, what is the status of the reflexes, and right upper quadrant or epigastric pain, is it present? Dyspnea, is it present? Nausea, vomiting, or any decrease in urine output. You should look out for all these symptoms and signs to forewarn you about end organ involvement. So what are the investigations you will order? Now, these investigations are ordered according to the severity of pre-eclampsia. So a total profile is what I have given you. A full blood count to tell you about any hemoconcentration, serum electrolytes, the coagulation profile, the renal function tests, the liver function tests, serum magnesium and serum calcium levels, blood for grouping and cross-matching, especially if you know that the patient may go in for postpartum hemorrhage or antepartum hemorrhage. Urine test, 24-hour urine collection. When you say 1+, 2+, 3+ in your history, the examiner is going to ask you, what do you mean by that? So it is 0.3 gram per liter, 1 gram per liter, or 3 gram per liter. Cardiotocogram, a USG, a UA Doppler blood flow helps the obstetrician to find out about the fetal status. Now, ultrasonography, another question commonly asked is, why is USG so important in the pre-eclamptic parturient for the anesthesiologist. First of all, you can assess the airway. Is there going to be any difficulty? The amount of fluid left over in the gastric system, the optic nerve sheath diameter, the vascular access because they are edematous. Neuraxial blocks again under USG guidance will be one-shot pricks. The lung USG to guide the fluid status because interstitial edema can be predicted early on. Interstitial, it is the first step towards an alveolar edema. So these articles have come out with the importance of fluid management and how important it is to base it individually. So the markers of end organ perfusion include urine output, the mental status of the patient, pH, and lactate. All these 4 tests tell you whether perfusion of end organs are good enough. A point of care bedside ultrasound examination also tells you, along with lung ultrasonography, whether the patient is heading towards pulmonary edema. A transthoracic echocardiography, which is a rapid obstetric screening echocardiography, also known as the ROSE scan, will evaluate the ventricular volume status and can help guide the fluid therapy. So we come to labor analgesia, and if any condition which provides the best epidural labor analgesia and is most productive for a laboring parturient, it is pre-eclampsia because it establishes and maintains the hemodynamic stability, prevents complications of pre-eclampsia like all those complications which occur because of an increase in blood pressure, because there's a decrease in the circulating catecholamines and an increase in the uteroplacental perfusion. Another important advantage is that it rapidly provides surgical anesthesia for cesarean section. We'll talk about the platelet counts, which are a deterrent towards providing labor analgesia. So we come to anesthetic management for cesarean section. What should you be giving? Regional anesthesia or general anesthesia for cesarean section? Now, regional anesthesia, remember, it's never a contraindication in severe pre-eclampsia, even after the patient has given a history of eclamptic fit at home or in the wards. Now, should you stop magnesium sulfate before cesarean section as it exacerbates uterine atony? A frequently asked question. Remember, it has a half-life of 5 hours. So if you stop it, you're not going to give any intraoperative benefit to the patient. However, the benefit you're giving the patient is that in the postoperative period, she will be susceptible to eclamptic seizures. So it's not a benefit, it's a big disadvantage for the patient. Now it is contraindicated in low platelet counts, which we'll talk in detail later on. So a preoperative monitoring will include all the usual parameters. Apart from this, a neuromuscular monitor and temperature monitoring is very important. Magnesium monitoring can be done with symptoms and signs. Urine output and fluid balance, equally important. Now, CVP and PCWP for pre-eclamptics is obsolete, and we have the better non-invasive cardiac output monitoring, or T and TTE. All these give an indication of the lung volume status as well as the left ventricular end diastolic pressure. Radial artery cannulation can be used in a poorly controlled hypertensive where frequent ABG is to be done. Intravascular volume status is dicey with obstetric hemorrhage. In such situations, you can go in for radial artery cannulation. Now, regional anesthesia, conversion of a labor epidural to epidural anesthesia. The examiner asks you, I want to give 2% lignocaine. Can I give epinephrine with it? Now, it does enhance the quality of the block. It also reduces the chances of any toxicity with local anesthetics. But if you inadvertently give it in the intravascular space, you're going to cause a surge in blood pressure. So it is always better to avoid it. Fluid loading before spinal, remember there's already a disruption of the endothelial glycocalyx, and any fluid will further disrupt it. So you're not going to give any advantage to the patient, rather you're going to increase the extravascular fluid volume. So it should always be a restrictive co-loading. Preferential use of vasopressors for spinal hypertension, phenylephrine, you need lower doses, around 25 to 50 mics suffice. So your concern is, if we ask you, the blood pressure is somewhere around 180 by 110, it's an emergency CS, would you go in for spinal hypotension, spinal anesthesia? Remember, the hypotension that occurs is less frequent, it is less severe, because the circulating catecholamines, there is increased vascular sensitivity to it. Less bolus doses of vasopressors are required. Only small doses of vasopressor, like 25 mics, are enough. And the hypotension which occurs is short-lived and easily treated. And it, of course, does not have any negative fetal outcomes. So spinal anesthesia is the best technique as far as pre-eclampsia is concerned, but provided the platelet counts are normal. Now we come to the important platelet counts here. More than 1 lakh is always safe. Between 75 to 80,000, perhaps safe. But between 50 to 75,000 is the gray zone, and less than 50,000 is pretty unsafe. Now remember, always remember, less than 80,000, your clot strength also declines rapidly because of the platelet quality decreases. Now, 2 additional considerations here. The trend of platelet count is very important, not a single value of your platelet count. So if in the last 24 to 48 hours, find out if it is stable. Is there any coexisting coagulopathy? If you are planned for cesarean delivery, your minimum 6 hours before you should have your platelet counts. And remember, when you are removing the epidural catheter, the count should be around 75 to 80,000. And early on, you can place your epidural catheters if it is between 80 to 100,000. So then, if your platelet counts are less, would you like to transfuse platelets? Now, there are 2 schools of thoughts here. One says that in pre-eclampsia, platelet transfusion would be of no help because it's a consumptive coagulopathy and the threshold levels would not reach. And of course, there are associated risks of Raleigh and overload if you give your platelet transfusions. And the ACOG recently in 2019 came up with, yes, if the patient is bleeding, if the counts are less than 50,000, you should transfuse your platelets. And before cesarean delivery, to bring up the counts up to 50,000, you should transfuse platelets. So what are we basically worried about? Why are we so worried about the platelet counts? It causes vertebral canal hematoma. But it is a rare incidence. 1 in 200 to 1 in 250,000 is the incidence in thrombocytopenic obstetric patients. But what is catastrophic about this is that it causes sensory or motor deficit and it has a poor prognosis unless you have a window of treatment of less than 8 hours to undergo a surgical decompressive laminectomy. Now, if the platelet count is found to be 52,000 per cubic millimeter and is stationary for the last sometimes 6 hours or so, can we do something to make neuraxial analgesia safer in such patients? Can these tests tell you that there will be no bleeding in the intrathecal or epidural compartment? APTT, PT, your viscoelastic tests, or your platelet function analysis, or your platelet aggregation tests, remember, none of them are going to give you any sign of bleeding unless the platelet count is less than 20,000, for which you will never do a regional anesthesia. So what you have in your hands is, have a skilled anesthesiologist perform your spinal. It should be a single shot spinal with a fine needle, a flexible wire embedded epidural catheter so that it does not enter the intravascular space, Check for neurological signs per-operatively and post-operatively. Platelet count before epidural catheter removal. And as soon as you suspect any paresis in the limbs, you should do an imaging and get a neurological consult. So, obstetric neuraxial anesthesia, an old dogma that said that you should not be giving it. Remember, the risk of spinal or epidural hematoma is just less than 0.6%. But the problems you face with general anesthesia, like intracranial hemorrhage and failed intubation, is 6.5%. So you need to decide and weigh the pros and cons here. So what are the major concerns with general anesthesia? Airway, a difficult intubation, always keep a small size endotracheal tube. Remember to keep your video laryngoscopes ready here. The risk of aspiration, you need to do an emergency intubation there. Rapid sequence intubation. Sympathoadrenal responses to intubation and extubation, very, very important to carry out. Labetalol 10 to 20 milligram or Maxelf 30 to 40 milligram per kg. Lidocaine can be given 1.5 milligram per kg. These two drugs are not available with us. Esmolol 2 milligram per kg can be given. Remember, this also has to be repeated in extubation. Don't leave it out for magnesium sulfate and NDMR. What is the problem there? We have a prolongation in the neuromuscular block. Respiratory depression may occur. Ergometrin, prostaglandins, strict no-no because it increases the blood pressure. Oxytocin should be given in small bolus doses up to 3 international units. Now, how does Maxelf prolong the neuromuscular block? Another interesting question that comes up. It inhibits the presynaptic release of acetylcholine, and in the postsynaptic receptors, it decreases the sensitization of acetylcholine. It depresses the excitability of muscle fiber membrane, increases the potency and duration of vecuronium, rocuronium, of mevacurium. With rocuronium, remember, in pre-eclamptics, on Maxelf and long-acting drugs, you always reverse it with sugammadex. There is no effect on succinylcholine. Now, fluid therapy is another important part which we need to take care of. 1 ml per kg crystalloids, and do not exceed it. In fact, now we have more non-invasive cardiac output monitorings, which can give you targeted individual fluid patterns, which can be decided. Transcapillary fluid shift increases with the rapid fluid, and there's a decrease in colloid osmotic pressure because of decrease in albumin synthesis, proteinuria, interstitial loss of plasma proteins. Remember, colloid should always be given under cardiac output guidance because it is not amenable to diuretic therapy. The dilemma here is whenever you have, you're thinking of fluid infusions, on the one hand, you have got intravascular fluid depletion. So if you keep the patient dry, you will end up with pre-renal failure. There is an increase in the extracellular volume. So if you try to load these people, then you're going to land up with pulmonary edema. So you need to keep a balance between these two. What are the complications you're looking out for? Pulmonary edema, hypertensive crisis, and eclampsia. 3 important complications that occur. Pulmonary edema, it's a pulmonary capillary leak, a decrease in colloid osmotic pressure, aberration in the left ventricular dysfunction, and you can appreciate it better in the slide. There is an increase in afterload with reduction in the lucitropy because of left ventricular hypertrophy. There is an increase in preload because of the microvascular forces. There is a reduction in the colloid osmotic pressure with altered permeability. If you look at the colloid osmotic pressures in the pre-eclamptics at third trimester, it is around 18 millimeter mercury, and in the postpartum period, 14 millimeter mercury, as compared to 22 and 17 in the normal parturents. So the major causes of pulmonary edema and pre-eclampsia: increase in preload, excessive fluid administration or a resolving puerperal peripheral edema. Cardiac causes could be diastolic dysfunction, a valvular heart disease, or a myopathic ventricle. Increase in afterload because of the hypertension. Colloid decrease on oncotic pressure and increase in capillary permeability. And of course, it could be a combination of all the other factors. So how will you reduce this risk? It should be a multidisciplinary team which is looking after the pre-eclamptic parturient, and close monitoring and avoiding the precipitating factors, especially NSAIDs try to avoid, fluids, your undiluted Maxel, syntocinon infusion, all should come in the intake output chart, and early management will help these patients. So you have to reduce the preload and the afterload. You have to ventilate these patients, intubate them, control the blood pressure with NTG, sodium nitroprusside or calcium channel blockers, diuretics, morphine, and if you have intubated and put the patient on a ventilator, then lung protective strategies with PEEP is the best management. Now, in severe hypertensive crisis, there is a confusion whether it is more than 160 by 110 for which keeps on for about 15 minutes, or it is more than 180 by 110. There are two schools of thoughts there. In any case, it is very important that you should not allow this hypertension to carry on for more than 30 minutes. Within 15 to 30 minutes, this should be resolved. And these are the drugs we already talked about. The aim of therapy is not to cause abrupt changes. It should decrease by 15 to 25%. And the target should be systolic blood pressure. Remember, it is the systolic blood pressure which heralds a stroke. So always take care of the systolic blood pressure. And the dangerous sequelae which can occur because of this is hypertensive encephalopathy or cerebrovascular hemorrhage, myocardial ischemia, or congestive heart failure. And that is why we say that a good anesthetist can prevent complications, long-term complications in the pre-eclamptic parturient. Now, there could be delayed recovery. What are the causes of delayed recovery in the pre-eclamptic parturient? It could be because of anesthetic agents or opiates, inadequate reversal of the neuromuscular block, and respiratory depression, which can occur because of magnesium. It could be hypoglycemia, or it could be an intracranial event. There are 6 different causes for this. Now we come to the HELLP syndrome. It's always a short note which comes. Hemolysis, elevated levels of liver enzymes, and low platelet counts. So antepartum, the incidence is around 70%, while the postpartum, it is about 30%. And more common with DIC, placental abruption, pulmonary edema, acute renal failure, and acute liver failure. And sepsis, stroke, ARDS, and it can lead to death. So the classic hallmark here is the microangiopathic hemolytic anemia, and you find echonocytes and schistocytes. And along with this, periportal hepatic necrosis and hemorrhage. So the Sibal's criteria says that there should be an abnormal peripheral blood smear, bilirubin more than 1.2 milligram per DL, LDH of more than 600, and AST of plus 70 international units, and a platelet count of less than 1 lakh. So if the platelet count is less than 20,000, always go in for random donor platelets. This is the only indication at present which says that platelet should be transfused before you take the patient for cesarean delivery. What is posterior reversible leukoencephalopathy syndrome? There is a lot of confusion whether it's a consequence of eclampsia or eclampsia is a consequence of this. And it is seen In cancer patients on immunosuppressive drugs, hypertensive encephalopathy, and in eclampsia. There is radiological evidence of vasogenic edema involving the posterior circulation, and it is triggered by an acute increase in blood pressure disrupting the blood-brain barrier. Now we come to eclampsia. Now eclampsia is what is like a bolt from the blue. It is defined as new onset of grand mal seizure activity or unexplained coma during pregnancy or postpartum in a woman who has signs and symptoms of pre-eclampsia. Now 80% of the seizures occur in the intrapartum period or within the first 48 hours of delivery. It is considered a complication of severe pre-eclampsia. So supposing a patient throws a grand mal fit as you are preparing the patient for surgery, put her in the left lateral position, this is in the ward, call for help, assess and support the ABC, prevent hypoxia and trauma. Remember, you should not push in an oropharyngeal airway when the patient is having a seizure. You are going to traumatize her teeth and tongue. IV access, start your MagSelf, monitor all the vital parameters and check on the blood sugar, whether it is because of hypo or glycemia. Then what can seizures lead to? Why is it dangerous? It can lead to placental abruption, DIC, acute renal failure, pulmonary edema, aspiration pneumonitis, and it can lead to cardiac arrest. Now the patient has been planned for a cesarean section. So what are the indications for eclampsia when 100% the patient has to be taken for a CS? It could be a transverse lie, malpresentation, placenta previa, cephalopelvic disproportion, uncontrolled recurrent convulsions. There are no anesthetic indications for taking an eclamptic woman for cesarean. Remember, when you go in for cesarean section in eclampsia, it causes higher morbidity and mortality. Now, post-operatively, the first 6 weeks are very critical. There should be continuous postpartum monitoring for 48 hours with oxygen, MagSelf, antihypertensives, and thromboprophylaxis should be given. Monitor the blood sugar, the ammonia levels, fluids and blood transfusion and urine output. A strict intake output chart should be there. These patients should be kept in comfortable and quiet environment. And what are the complications you are looking out for in the postpartum period? A hemorrhagic stroke, eclamptic seizures, peripartum cardiomyopathy, a venous thromboembolism, or a HELLP syndrome. So provide them with good analgesia in the postoperative period because it can precipitate a seizure. Wound infiltration, TAP block, intrathecal opioids, ketorolac, ibuprofen, paracetamol. Remember, you need to avoid your NSAIDs there. So which eclamptic patient should be sent to the ICU? Severe hypertension with neurological symptoms, severe oliguria, any of the end organ diseases, if they are affected, you need to send them to the ICU for better management. So what are the post-preeclampsia outcomes? The risk marker for later life diseases. With eclampsia, ischemic heart disease, chronic hypertension, stroke, also seen with severe eclampsia, preeclampsia, and acute renal failure can go on to become a chronic renal failure with acute tubular necrosis, renal cortical necrosis. So this is why we say there's an important role of anesthesiologists to maintain a stable hemodynamics during anesthesia for cesarean delivery. So the last 2 slides, what are the case dilemmas we face? A laboring obese parturian with severe preeclamptic requests an epidural analgesia. Her VAS score is 9/10. Her platelet counts are somewhere around 70,000 per cubic millimeter. They are stable for the last 6 hours. So would we say that we are not going to give a neuraxial block because you are worried about the rare complication of SEH. And the second important scenario, it's an emergent cesarean section in a severe pre-eclamptic, morbidly obese parturient with full stomach, a difficult airway, MPS is 4, platelet count is 60,000. So would you give a general anesthesia or would you give a single short spaniel? So these are some of the dilemmas you need to address when you talk about pre-eclampsia.
Thank you, madam, for an excellent talk on preeclampsia. And you can stop sharing your screen, and there are certain questions also which have come up. Not many. One is, and I request all, I'll give the permission to unmute also. And you can unmute yourself and ask questions directly also. Madam, should I put the questions which are there in the chat box? Madam, you are muted. Yes, ma'am. If you can stop sharing the screen. Don't leave meeting, ma'am.
Is it still sharing?
Yes. Okay. I'll stop sharing from my own. Okay. The questions which are there are, ma'am, there are certain queries. One is about the esmolol dose to prevent the intubation response. What should be the dose of esmolol, and how to confirm the location of epidural catheter?
Yeah, the esmolol dose is 2 milligram per kg body weight. And how do you confirm the location of the epidural catheter? The best way to confirm the position is ultrasound guided technique. But if you do not have an USG, then of course, aspiration, and there are no new techniques about locating the position.
Maximum dose of oxytocin that can be administered in a C-section delivery after delivery of the fetus in normal/high-risk pregnancy.
In high-risk pregnancy, what we do is, according to the response of the patient, you should not, each bolus dose should not go about 3 units, international units. And infusion should be 40 international units and 1 liter of your fluid.
Right. Then another is on walking epidural. That's also come up. What is the walking epidural?
What is the?
Walking epidural block.
Okay. Walking epidural is when you give low doses of your local anesthetic solution in the epidural space. It is 0.0625% of bupivacaine along with 2 microgram per ml of fentanyl that you start with. And then you can go up to 0.125% of your bupivacaine. And with this, the patient can walk along, but she has to be supported. You should never leave the patient alone. So this provides a walking epidural, and 10 to 15 ml of this dose is what we call walking epidural. So essentially, she does not have any paresis in her limbs, and that is why she can walk along.
Right, ma'am. Why monitoring of potassium is required before administering medicine?
Why?
Monitoring of potassium is required.
That is because we are worried about any arrhythmias that can occur with intravenous magnesium sulfate and potassium hyperkalemia.
Can we use labetalol in pulmonary edema?
Can we use labetalol in pulmonary edema? We would rather, if you want to bring down the blood pressure in patients who have already gone into pulmonary edema, labetalol is not going to be effective, and rather you should always go in for 5 microgram per minute of your nitroglycerin. You can go up to 100 microgram because you want to reduce the blood pressure there in a more effective manner.
Preferred thromboprophylaxis for an eclamptic patient in postoperative period.
In the postoperative period, this should be started if it is therapeutic or prophylactic. If it is prophylactic, then you give your enoxaparin about 40 milligram once a day, or if it is therapeutic, you give it twice a day. While if you're starting with UFH, which you already shift on LMWH, from LMWH, you always shift to UFH around 36 weeks of pregnancy. And you may want to continue UFH in the postoperative period, but then it should be started only after 24 hours. So about 5 to 10,000 units is the dose there.
Right, ma'am. Choice of anesthesia in a pregnant woman post-eclamptic seizure requiring cesarean section.
So post-eclamptic seizure, if the patient does not have subsequent seizures, the patient's mentation is adequate, she responds to you, and she's not unconscious, not comatose, then you can go in for spinal anesthesia. But supposing her cerebral mentation, the Glasgow Coma Scale is deranged, then you need to put the patient under general anesthesia.
Slightly related question. After how many hours of seizures can I give spinal anesthesia?
After how many hours of seizure? Well, if the patient has had a seizure in the ward and then the obstetrician decides that we need to take her immediately because of fetal distress, you can give your spinal anesthesia.
How do we decide preoperative platelet transfusions target to bring pre-op platelet count up to 50,000 or 80,000, since you suggested that clot strength decreases below 80,000? And also, it is a consumptive coagulopathy state. Basically, they're asking about preoperative platelet transfusions, whether how to go about it to bring the pre-op platelet count up to 50 or 80,000.
Well, we start with random donor platelets, 6 units, and then see how much is the rise in platelet count. It increases by about 30,000. So one unit of RDP should be sufficient there.
Lots of questions coming in. Can you please tell the duration from spinal to fetus extraction and from skin incision to fetus extraction?
Why am I not able to see it?
They're all the chat box, ma'am.
Yeah. Achha. What
you can take it directly also yourself.
Yeah, that's what I was wondering.
Uh-huh.
Choice of anesthesia we finished, and then can we get a presentation of how to confirm epidural catheter location?
All go down, ma'am. Come down.
Prevent intubation response. Can we use labetalol in pulmonary edema? What is this? Please repeat dose of oxytocin. Ma'am, can you please tell on duration from spinal to fetus extraction and from skin incision to fetus extraction and uterine? Oh my God, what is this question? Uterine incision to fetus extraction. Now, what does this mean? Namrata from Karnataka is asking. Well, the decision delivery interval from the decision of the obstetrician to the delivery of the fetus should be within 30 minutes. And that is according to the NICE guidelines. So then you can decide between skin incision to fetus extraction and all those points. Can we give sublingual nifedipine? Definitely not. We should not give sublingual nifedipine because it causes a precipitous fall in blood pressure, which is going to be really dangerous for the mother, and it causes subarachnoid hemorrhage. Diazepam won't affect the fetus in eclamptic mother not controlled by MACSELF. Not controlled by MACSELF. Definitely it will affect, and the neonate has to be transferred to the neonatal ICU. But what we are looking at is we have to save the mother. If the eclamptic mother is unable to, MACSELF is unable to control her fitting, then we need to give drugs like diazepam. Can the spinal be given even if the patient's general condition is poor, like if the patient is drowsy? No. In that case, I would advise go in for general anesthesia. Ma'am, how to manage a case of severe preeclampsia that developed pulmonary edema postoperatively? I have already told you about that, how to manage the pulmonary edema in the patients, whether it is post-op, the management is the same. Should we lower the doses of neuromuscular blockers in general anesthesia, and by how much in a woman who has just received MACSELF? Should we lower the doses of neuromuscular blockers in general anesthesia? See, MACSELF in every case does not cause neuromuscular, profound neuromuscular block. So your doses of neuromuscular block should be according to your neuromuscular monitoring. Kindly discuss the case dilemma too, ma'am. Okay, those two cases. Yes, I'll come to it. Can we use Levipril for seizures? Sorry, I've not heard about it. Levipril for seizures? No, I have no idea whether it can be used in obstetric patients. Platelets for regional anesthesia, we have already discussed. Blood pressure optimization before spinal and general anesthesia in severe preeclamptic mother. Now, optimization of the blood pressure before spinal anesthesia, supposing if it's an emergency cesarean section, you do not have time for, the obstetrician does not give you time, just half an hour maybe, your dose of labetalol 20 milligram repeated after 20 milligram would be adequate. With general anesthesia, optimization would be same if it's an emergency. Otherwise, you can take about 24 hours to optimize these patients with labetalol or nifedipine before you give your spinal or general anesthesia if it's an elective cesarean section. Can we use supraglottic airway in case of drowsy patient in cesarean section? See, supraglottic airway should always be used in a drowsy patient only as an emergency procedure. If you can intubate the patient, that would anytime be better as compared to a supraglottic airway in a drowsy patient. Now, what is the dose of LA in analgesia? For labor analgesia, the dose of local anesthetic, I presume that is what you are asking. It is start with 0.0625% and 2 microgram per ml of fentanyl. That suffices, and you can go up to 0.125% of bupivacaine. Now it depends. I always advocate that your epidural should be placed according to your platelet count. So if the platelet, you can even put your epidurals before the patient has any severe pain. In that case, you just give your epidural opioid, 25 mics would suffice there without any local anesthetics. If a patient of severe preeclampsia lands into PPH, what is the management? Severe preeclampsia landing into postpartum hemorrhage, that would be total management of obstetric hemorrhage. That is why we kept the blood cross-matched and ready. Ideally, it should only be with blood, packed cell, 1:1:1 ratio. That would be ideal here. PIH with mitral stenosis management, that is a completely different ball game with mitral stenosis. Unless there's some complication, the patient goes into pulmonary edema with mitral stenosis. If it is mitral valve, which is less than 1 centimeters, I would always advocate that you need to release that mitral valve and as an emergency. Otherwise, that pulmonary edema will never be corrected. What should be the induction to delivery time, ideally? Induction to delivery time, ideally, should be within 15 minutes. Monitoring in severe case. Monitoring in severe case. See, what you need to do is your left ventricular and diastolic pressures you need to monitor, as well as your lung status in the severe pre-eclamptic parturients. So monitoring here would require a non-invasive cardiac output monitoring along with your TTE or TO, and you give a radial artery cannulation to this patient, because in severe cases, you also need to know your ABG values.
A related question has come up privately, ma'am. This monitoring in severe cases, continuous intra-arterial blood pressure monitoring.
Yeah.
Role in severe cases.
Yes. I would prefer that, continuous monitoring of the arterial blood pressure. Proning in pregnancy. Why do you want to prone in pregnancy? Not
COVID.
What precautions to be taken to prevent acute renal failure and how to treat it after LSCS? What precautions you need to take to prevent AR? See, in severe preeclampsia, the only way you can avoid acute renal failure is by adequately loading the circulation, but it should be under your ultrasound guidance or under your guidance of the cardiac output. That is the only way that you can solve this problem. But you also need to look out for your pulmonary edema, that the patient doesn't get, is not susceptible to pulmonary edema. And how to treat it after LSCS. Well, the only way out is infusing fluids, and if it occurs acute renal failure, then diuretics and the two ways we take care on that. How to monitor the fluid status intraoperatively if transthoracic ultrasound is not available? A very difficult question to monitor the fluid status intraoperatively. Luckily,
all the lectures.
The prophylactically, you should always, prophylactically, you should not go beyond 80 ml per kg. And that is how you avoid any, you avoid any overloading of the circulation. And monitoring the fluid status, either you go for central venous pressure in that case, or you, along with your intra-radial catheter, radial cannulation. That is the only way you can find out. Levipril is a weak anti-leper, generally not used in obstetric practice. Okay, your talk, and you are very nice, Dr. Sunanda. Thank you. Analgesics for breakthrough pain in labor and anesthesia. Analgesics for breakthrough pain in labor analgesia. Well, if you have given 0.0625%, you increase the concentration to 0.125%. And you can also, if it is patchy analgesia, put the patient on the area which is not analgized. You can turn the patient onto that side and give a dose of fentanyl. Similarly, if the patient in the later stages of delivery, if the patient has severe perineal pain, then you can make the patient sit up and give a dose of your opioid there. A patient who has an epidural catheter in C2 develops severe thrombocytopenia. When is it advised to remove the catheter? Patient who has an epidural catheter in C2. Well, the epidural catheter should only be removed if the count comes up to 75,000. And unless it comes up to that, you should not be removing the catheter. Whether you transfuse platelets and improve the counts, and once the placenta is out in the postoperative period, the thrombocytopenia, if it is related to pre-eclampsia, would definitely come up in the next 24 to 48 hours. Use of uterotonic agents in PIH, please do not give your ergometrin here, and that causes a substantial rise in the systolic blood pressure, and it has also been known to cause cardiac arrest and hypertension, myocardial infarctions. Maximum duration that epidural catheter can be kept in C2. Well, epidural catheters for pain relief in cancerous patients have been kept in C2 for 7 to 15 days. And even for longer periods, they have kept it, but ideally not more than 7 days. Thank you, ma'am. Thank you so much. Thank you, ma'am. Thanks for presentation. Postoperative headache and post-dural puncture headache. How do you differentiate between postoperative headache and post-dural puncture headache? Well, post-dural puncture headache is very typical. It will appear with nuchal occipital headache, and postoperative headache most commonly has a frontal distribution. And of course, if it is pre-eclampsia, you have more chances of post-dural puncture headache there. So nothing much different. We had a recent case of elderly primey, G2P1L1 pre-eclampsia with pulmonary edema, difficult airway, obese, her SpO2 was 80%, but conscious and obese commands and increased to 98% on pain circuit. My consultant is an expert. He did combined spinal epidural and patient was later connected to HFNC postoperative. Do you think GA would have been a better choice? You said that her SpO2 was 80%. And I wonder what was the reason for that. Well, because of pulmonary edema. Now, was it frank pulmonary edema, but conscious and obese commands, and increased to 98% on vein circuit. Now, increased to 98% on vein circuit means after the patient was on spontaneous ventilation and on vein circuit, it increased to 98%. Means when the patient was oxygenated, she improved her oxygen levels to this. So, yes, the way your consultant managed it was really good, because a difficult airway anytime can land you to more problems as compared to an combined spinal epidural. Yes, that was a good way to manage this patient. Elaborate, madam, can you use pulmonary artery wedge pressure monitoring for fluid management in pulmonary edema with PIH? No. The pulmonary artery wedge pressure monitoring is a total no-no for PIH patients, because they tend to with the pulmonary artery wedge pressure, you are not going to achieve anything, because you will find an increase in all cases, as well as the CVP. It does not correlate the central venous pressure and the pulmonary artery pressures do not correlate, so it is of no use there. Should we stop max self infusion during general anesthesia before how much time? Max self infusion should never be stopped before general anesthesia, because you need to continue max self, because the half-life of max self is 5 hours, and even if you stop it before that, then you are not giving it any advantage in terms of neuromuscular blocking. What you are doing is precipitating seizures in the postpartum period. So max self should never be stopped. Excellent interactive session. Thank you. Thank you. After what duration spinal can be repeated, ma'am? What does that mean? After what duration spinal can be repeated? I wonder what.
Probably they're talking of failed spinal.
Failed spinal. So, well, you can immediately turn the patient onto the left side and again do the spiny in a different space. We regularly do it, right? Sorry, elderly multigravida. Thank you, ma'am. Please discuss the cases. Yes, I have to discuss the cases. I'm just waiting.
After spinal anesthesia, patient vomits on table. What are the differential diagnoses and how to manage that?
ये तो मेरी क्लास ले रहा
है. I was thinking that you are supposed to ask certain questions.
Yeah, I know.
and it's a rapid fire round on you.
I know they are putting pressure on me. The most important thing is just see that the patient is going into hypotension. That is the most important cause of vomiting in immediately after spinal. And apart from this, if the SpO2 is falling, these are two major reasons why the patient vomits. And the third important reason is your oxytocin, which you have given. So 3 important causes why patients vomit there. How to manage sudden severe fall in blood pressure below following spinal? Just give your phenylephrine. If your heart rate is normal, just give 25 mics of phenylephrine. How to differentiate PDPH from late onset postpartum eclampsia? Well, postpartum eclampsia will always be followed by your seizures too. Role of Sphenopalatine ganglion block. Now, what is this?
They must be talking about sphenopalatine ganglion block in PDPH.
Oh, sphenopalatine ganglion block. Well, it is sphenopalatine ganglion block is supposed to have some positive effects for post-dural puncture headache, and still in research stages. Not many people are still using it. Sphenopalatine, yeah. Okay. The 2 questions, can I go back to my slides then if there are no more questions?
Yes, ma'am. Please go ahead.
Sharing is not all that easy.
It's loud, madam. Please go ahead. And I'm muting all, so you can unmute yourself.
Okay. Can you see the slide?
Yeah, ma'am, you have to make it full screen only. That's fine. Okay, ma'am.
So my question was, a laboring obese parturian with severe pre-eclampsia. She requests epidural analgesia. Her VAS score is 9/10, 70%. for the last 6 hours. So will you be giving her neuraxial block due to concerns? So a laboring obese parturian, can I be heard?
Yes, madam. Yes, madam.
So a laboring obese parturian, severe pre-eclampsia, she wants epidural analgesia, VAS score is 9/10, platelet count is 70,000 and stable for the last 6 hours. Remember, I told you, your last count should be at 6 hours. And now she's asking for a neuraxial block. So I told you that the incidence of SEH is just 0.6%. So you can safely go for that block, but you need to be very cautious that the neurological status in the postpartum period should be checked for 6 hours till you are fully satisfied that the patient has come out of your neuraxial block. Any suspicion, you should call in for your neurological consult and a radiological evaluation. The other question is emergent cesarean section in a severe pre-eclamptic, morbidly obese parturian with full stomach, difficult airway, platelet count of 60,000, GA versus single short spinal. Now, you need to find out the platelet count, minimum 6 hours duration, and you can safely go in for a single short spinal, but it should be by an experienced anesthesiologist, and a fine spinal needle should be used. So that is it. Naveen, if there are no more questions.
But one or two last one coming up for you, and then we can definitely wind it up. And role of NTG in eclampsia and severe preeclampsia.
Role of NTG in eclampsia and severe eclampsia.
Eclampsia and
Severe pre-eclampsia.
Yeah.
Yeah, NTG is advocated for severe hypertension, 5 microgram per minute, can go up to 100 micrograms, and that is allowed. Anything else?
No, I think you have almost answered more than 100 questions, and so that
I could not get to ask questions from the students, you know.
You can ask now, ma'am. You can ask now.
No,
I can give them permission to unmute themselves, and they can answer your questions. Please go ahead if you want to do so.
So one of the common questions that everyone asks is about magnesium sulfate. It is a vasodilator. So how does it help in the CNS changes which occur in preeclampsia?
Yes, students who are going to take up this particular question. Since you have asked so many questions, now it is your turn, and you have been given permission to unmute yourself and answer it. So let it be a both-way thing.
I think they are totally exhausted now and they are going to leave. So maybe Naveen will call it a day.
No, ma'am, really, to be honest, it was a practically useful class, and lots of good discussions happening. And all credit to you for making it very interactive and very informative also. I would have appreciated if it would have been a both-way process so that they could answer your questions. But I think in between you should ask questions. So I will proceed further. Next time I'll ask the speaker to ask questions in between.
Yes, that should.
And so that you proceed later on.
Yeah, there are. I don't think anybody answered that in the chat box also.
Sir, can I speak, sir, regarding magnesium? This is Namrata from Bangalore, sir.
Yeah, Namrata, please go ahead.
Sir, magnesium, like how, even though it's a vasodilator, but like sustained increase in BP forces vasodilation to happen. That causes cerebral edema, and it causes this ameliorates it reduces the inflammation of the brain edema also, and protects the blood-brain barriers, and it acts as a NMDA receptor antagonist also. So to increase the seizure threshold.
Yeah, and basically it increases the vasodilatation, the mesenteric vessels. It does not have so much of effect on the cerebral vessels. Good, very good, Namrata. You asked a lot of questions I saw in the chat box.
Any other question from your side, madam?
I think we have crossed the limit. 5:30 it is already.
I take this opportunity to inform all the students and seniors who are attending this particular online PG class that our ISA National Advisory and Position Statement on second wave of COVID pandemic and sudden surge of mucormycosis, lessons learned and future preparedness is now on WFSA website also.
Wow.
They have
That's a great achievement.
given very good comments about it and found it useful that it should be shared with all the countries across the world. So it's all has been possible because of inputs from all the members across the country. With this, I thank Madam Sunanda Gupta ji for your excellent presentation and nice discussions. We shall meet next Monday, same time. Thank you very much.